Hello, and welcome to this COVID-19 Town Hall on supporting clients' mental health during isolation and quarantine. I'm Lily Catalano, Project Manager for the National Healthcare for the Homeless Council in Nashville. As people experiencing homelessness, healthcare providers, and the HCH community grapple with the stress, grief, disruption, and uncertainty of the COVID-19 pandemic, there are serious implications for individuals' mental health. Service providers are bringing their skills, creativity, and empathy to support their clients' mental health when facing isolation and quarantine, and we'll explore some of the ways they're doing so in this town hall. Our format for today's hour is a coffee chat. We call them coffee chats because they're informal discussions. We invite you to get a cup of coffee or your lunch and listen and discuss. This is an opportunity for us all to share ideas, challenges, and support for each other. We hope you'll engage throughout. One of the best parts of a coffee chat is getting to hear from people doing similar work across the country. Today's panelists come to us from the Healthcare for the Homeless Clinicians Network, which is the nation's largest network of providers of hands-on care to people who are homeless. The network helps members connect, learn from each other, and share best practices across the homeless healthcare field. If you're not already a member of the Clinicians Network, please join for free via the link on the resources pod on your screen. And the Clinicians Network also has a Facebook group that's open to its members, and you can also join that online community today, also in the resources pod on your screen. So some instructions about how you can engage during the chat today. We want to hear from you, and we welcome your questions and stories throughout the chat. The more you all engage, the better it will be, and you can type directly into the attendee chat pod on your screen. Many of you are saying hello already, and it's so great to see folks saying hi and welcoming each other, so you're off to a great start. Your comments will show up to all the participants, and I'll refer them to panelists as I can throughout the chat. Also, feel free to respond to each other as you see folks asking questions or sharing stories. So first up, let's see who we've got participating today. We have a nice big crowd. I'm going to post a poll question on the screen that will show up to you in just a moment. So you should see there, what type of organization do you represent? Are you from a Healthcare for the Homeless program? Are you from another health center or a shelter or another type of service provider? And as you see, you can click right there on the screen, your response, and we can see everyone's answers showing up at once. So it looks like about a third of folks are from Healthcare for the Homeless programs, some more from other health centers, about a fifth maybe from shelters, and then half or more than half of us come from other types of service providers. So thanks for responding. I'm going to post one more poll question. And it should show up for you now. This is just about your current role. Are you a clinician, an administrator, a consumer? Do you work on the government side or policy and advocacy? So if you would, take a moment and click your answer. All right, it looks like we've got about a third of our group today is clinicians, about a fifth maybe is administrators, a few from government and policy sides, and then a lot of other types of roles, almost half. So thank you. Before I introduce today's panelists, I want to point out the COVID-19 resources link on your screen in the resources pod. You can click that link and find all kinds of COVID-19 guidance specific to homelessness that's been created by the National Healthcare for the Homeless Council and other partners. And I'm actually going to open that link right now, and that should open on your screen as well. So please take a look after the town hall or during, if you like, and see what we've got there. There may be lots of things that may be useful to your work. Okay, if you need to, you might need to click back to the original window for the coffee chat or a different tab, but if you're back there now, I'm very excited to introduce our panelists today. They are Lawanda Williams from Healthcare for the Homeless in Baltimore and Catherine Crosland from Unity Healthcare in Washington, D.C. Welcome. I'm going to invite each of you to tell us a little bit about yourselves and your organization.
Hi. Thank you all for joining today. I'm so pleased to be spending this time with all of you. My name is Lawanda Williams, and I am the Director of Housing Services at our Health Center in Baltimore, Maryland, our Healthcare for the Homeless Center. We are located in downtown Baltimore and provide a number of services for individuals experiencing homelessness. My work directly is working with our supportive housing programs, and we provide housing assistance and services to over 400 of the most vulnerable individuals exiting homelessness and entering into housing. So we provide a lot of support to individuals, providing intensive case management services, therapy services, peer services, as well as linking clients that we're working with all of the other services that are available through our health center. So we have, I'm very interested in having this conversation with you all and sharing what we are doing in Baltimore and also learning from this group. Thank you for having me.
Thank you, Lawanda. This is Catherine Crosland. I have to warn you that I am at our isolation and quarantine site, and there's not really a quiet space, and so right now I'm in the parking lot, so I apologize for any background noise. So my name is Catherine Crosland, and I work with Unity Healthcare, which is originally founded as Healthcare for the Homeless D.C. in 1985, and we are now the largest federally qualified health center in D.C., but we still have a focus on serving the most vulnerable population, including people experiencing homelessness. We have a Healthcare for the Homeless kind of branch of our organization. I have helped to direct the outreach program for the past 10 years in the shelters, on the street, in day centers, but my current role is actually as the medical director for our emergency response sites. The Department of Human Services in D.C. has contracted with 4 hotels and soon to add 2 more to that. And these include 3 hotels, which are isolation and quarantine sites that are used for folks in congregate settings, mostly shelters and encampments, who either have symptoms who need to be tested, people who have known COVID who need isolation, and also now contacts of known cases who need 14-day quarantine. And then the other site is what we're calling our site for high-risk individuals, to proactively try to protect them and quarantine them so that they don't get exposed. And this is, it's called PEP-V, the Pandemic Emergency Program for Highly Vulnerable Individuals. And so we essentially hold everybody in the whole city to get this group together, 125 people within our 4,000 person population of people experiencing homelessness currently. And so these are folks who are older, who are medically vulnerable, and sort of are what we consider to be high-touch clients, and dialysis, et cetera. And mental health and behavioral health issues are highly prevalent in the populations, both at the isolation sites and the PEP-V sites. So that's what I'm up to right now. So most of my perspective on this comes from that setting.
Thank you. And just like Catherine mentioned, I think many of us are working in physical settings that are not our typical workspace and maybe sharing space with loved ones and pets and kids. And in the midst of all that, I'm so grateful that we're all finding a way to connect here. And if anyone has background noise or anything that comes up, that's fine, and that's part of it. So no worries there. Let's jump into some discussion questions. I'll ask the panelists, and then I also invite any attendees to respond in the chat with your perspectives or any follow-up questions that you want to ask our panelists. So first off, what are the major challenges to individuals' mental health that you are seeing during COVID-19?
Yeah, this is Lawanda. I think one of the things that we have seen as a major challenge to mental health is really a sense of a loss of community. Many of the individuals who we serve have communities that they move in and out of, just like all the rest of the population. And I think the abrupt loss of those communities has been a significant challenge for clients. You know, I think one of the things that bears mentioning is that for the general population, when those things happen and there's an abrupt shift, many people have alternatives and backups that they can lean to that allow them to recalibrate themselves pretty quickly. So as an example, you know, someone who might be challenged with not being able to reach a loved one, as an example, or go see a loved one, might have ready access to the internet or access to online platforms to be able to really connect with individuals pretty quickly. Our clients, I think, have those disruptions and may not necessarily have the kinds of tools available to them sometimes to be able to make those shifts quickly or have those resources available to do that. And so I think that sudden disruption, you know, I think is one thing. I think another thing that we have experienced as well is that there is a significant amount of uncertainty that's inherent to this current environment that we're trying to navigate. And so that, coupled with many of the other myriad of issues that our clients face, it sort of feels like one more thing. And so we've noticed in Baltimore that we've had a lot of clients who are really struggling with finding a sense of purpose and a sense of connection during this time. And I think, you know, we've been really intentional about trying to help people find ways to remain connected. But I think those are the biggest things that we have seen. And I think, you know, thirdly, some of the issues that come from that uncertainty are really things that are very core to one's ability to exist. So the uncertainty around transportation and knowing that the very transportation that you rely upon to be able to get to the things that you need is the very thing that everyone is saying you shouldn't be doing in order to maintain safety. So there's a bit of irony in this, in the sense that for people to get to where they need to be, to do the things that are very important, rely very heavily on using oftentimes mass transit in ways that you are not able to maintain social distancing, which is the thing that is being advanced and we know will keep us all safe. And so there's a bit of discrepancy and sort of cognitive dissonance in that that people have to reconcile, and I think that causes some strife and some concern and anxiety, to be quite honest, for people. I think the same could be said for things around food security as well. I think those are the major things that we are seeing as impacts to people's mental health and well-being right now.
Thanks, Lawanda. So I think that, though I totally agree with everything that Lawanda said in terms of sort of fractured sense of community and service providers that folks are sort of have come to rely on, not only to get them their medications physically, maybe like their monthly injection, et cetera, but the face-to-face encounters, the group centers, I mean the day programs that folks go to for that sense of community. What we have seen is a lot of providers, mental health providers, outreach workers have scaled way back their operations. So there's a lot of telehealth or phone check-ins which can be really challenging for our patients who don't have phones, for example. So I do think that there's a real sense of sort of alienation when those services have been cut off. So I would just say for the three kind of main populations that I see, one is folks in the shelter. So the shelters are now open 24/7, which in some ways I think is a really good move because people aren't getting kicked out in the morning and being made to go across town and sit in a day center, et cetera. At the same time, there is a sense of people being kind of shut in, and they're not forced to stay against their will, but their exit from the shelter is not being facilitated anymore through our shuttle system. And so I think that a lot of people are feeling kind of overcrowded and cooped up, and it exacerbates some of the mental health issues, not to mention the fears of exposure when everybody's saying social distance and you're in a dorm room with 60 other people. Now, not 12 hours a day, but 18 hours a day or 22 hours a day with a couple hours out in the parking lot, that kind of thing. So the other thing is people who are street-bound homeless. The outreach workers' hours have been cut back significantly, so folks who rely on that kind of daily check-in from folks aren't getting that. At the same time, businesses have shut down, and there aren't as many passersby, so people who rely on food from passersby or going into establishments to warm up or to get food don't have that option. So I think that there is a lot of food insecurity, as Lawanda said, and a lot of the day programs that offer meals have been cut back. For folks in the shelters, they're getting meals 3 times a day, but for the folks who are out in the park or on the street, their options for getting meals is significantly reduced, coupled with just a lack of ability to access day centers for showers and laundry and hand washing and sort of basic hygiene in a time when everybody's been being told to really be mindful of hygiene. So those are the two populations. And then I would say at the sites where I'm currently spending most of my time, people are being brought voluntarily to these sites for quarantine or isolation, but then a lot of times their community health workers, or sorry, their mental health providers are unaware that they have been brought to these facilities. And so what we're trying to do as the medical providers on site is to try to figure out how can we better communicate when somebody comes in, if this is somebody who has an ACT team, so that we can make sure that their ACT team knows that the person's here so that they can maintain that sense of connection. So these are issues, and also they may not have their medications and they don't have the ability to then go pick up their medications because they're in quarantine without the ability to freely come and go. And so these are real issues that we are struggling with. And the final thing I would say is the behavioral health or the addiction issues. So people, from everything from nicotine to opiates to alcohol to other substances, people, right, when folks come in, we're realizing that trying to get a sense of what kind of supports people need around nicotine replacement or maybe detox for alcohol, Suboxone, et cetera. These are some of the major issues that we are seeing with our patients, and just a lot of anxiety. I think it just provokes a lot of underlying anxiety, depression, et cetera.
Yes, thank you both for giving sort of the macro level view of so many issues that are coming up for folks right now, so many challenges, and the attendees, you are all really echoing these and bringing up some other areas that we want to explore during this chat. Let's focus in on this isolation piece first. And are there ways that you all are finding that are helpful in helping your clients stay connected to families, friends, and service providers in spite of the many connections that have been disrupted?
Hey, Lawanda, I'll go first. I've been relying on you to go first every time. So I think that we are, from the isolation and quarantine and the PEP-V sites, I think it's really about trying to improve our communication, right? So we need to figure out who to notify HIPAA compliantly, and just make sure that that folks don't lose those connections. Sometimes the clients or the patients are very good advocates for themselves in terms of saying, I need to see my case manager, or my case manager is supposed to bring me my medications, but then there are other folks who may not have that level of self agency in terms of advocating for what they need. And so that can be a challenge for us to, if we don't know what somebody's needs are. So trying to figure out how to kind of communicate that. I think that the other thing that we're relying on a lot of is sort of word of mouth, and the few day centers or day meal programs, et cetera, that are still operating. We're trying to push out as much information during those times with flyers and information, so that folks who attend those breakfast or dinner programs can then pass that information to their peers. So yeah, I think there's just been a real need for increased level of communication and cooperation to care for this population.
No, I would certainly concur. I think we've relied quite a bit on, communicating out. We've done some things to try to be really proactive about meeting the needs of our clients. So one of the things in Baltimore we did very early on with respect to our clients who are part of our permanent supportive housing program, and certainly across the agency too, is being really intentional about reaching out. We do have a fair number of clients who have phones, and so we're making phone calls twice a week. We have a pretty aggressive outreach plan to get information out to clients. While we have been dissuading individuals from coming into the clinic, that certainly does not mean that we have not been in touch with them. And in fact, making sure that we get information out to clients. We are in contact constantly with folks across our agency in terms of policy team and advocacy teams, really trying to get any information that we can and what's happening at the state level, the local level, pushing out that information to our clients. So if there are things that are changing with respect to issues around eviction protections that are in place right now, issues around BGE protections right now, things around court involvement, things around food distribution sites and where people can get masks and face coverings. So all of that kind of information that we're trying to proactively get out to clients. Sometimes, as Catherine mentioned, our clients might not necessarily articulate everything that they need, and so we are, really aggressive in trying to make sure that we keep our finger on the pulse about what's happening and using all of our resources, both internally and externally, to gather that information so that we can get it in the hands of our providers and our clients.
Thank you. Lawanda, you mentioned the role that phone outreach can be so helpful, and several folks have mentioned that in the chat as well, although folks are also pointing out that lots of clients don't have telephones. So what sort of options are available for clients without access to a phone? And let me ask the audience if any of you know of any organizations that are providing devices to people experiencing homelessness during this time. If you do, go ahead and type that in.
Yeah, so a couple of things with phones. We actually have found in our work that more people had access to phones than we thought there would be. We thought there would be a higher proportion of individuals who did not have phones when this started, and we expected that to be a huge issue. It is an issue, but it's not the portion of people who we expected to not be reachable by phone is smaller than what we initially anticipated. So I think that's worth saying. I think there was some conflation around people having minutes on their phone available to them and people actually having phones. And so one of the things that's been happening, at least in our neck of the woods, has been that many of the government-related organizations that provide the free phones for individuals have done things with unlimited minutes. So there are a couple of agencies, Q-Link, Assurance Wireless, and some others who, if clients have phones through those companies, they are actually providing unlimited minutes right now. And some have agreed to do that through April. There are some that have agreed to do that through May, and we suspect that that might even extend, along the course of this health crisis we're facing. So I think that in itself has created an increase in people's ability to have access to minutes for their phone, because those plans are typically limited in terms of the number of minutes that are provided. So that's been nice to see people have that kind of access. But I think for us, it's really been setting targets around how often we reach out to clients, and we had started this off knowing that people will have lots of questions and really wanting to do as much as we could. So we had some expectations in place that we would be reaching out to clients twice a week to check in with them, see if they had any questions, to see if they had any emerging needs, and just to see where we could be helpful. And to be quite honest, to be in person who's actually reaching out to them and to be able to connect in that human way. So I think we've done a lot of that. There are a proportion of clients who don't have telephones, and we are in the process of organizationally developing an outreach letter that will go out to individuals that explains the services that we provide, how they can get in contact with us, what they should do if they have concerns. That letter also outlines some of the conditions and symptoms that they should be concerned about and what to do in the event of those things, and then also describing how they can access their providers. For our team, we have maintained walk-in hours. We have felt that even with the desire to dissuade clients from coming in when we're able to reach them, we know that there are some clients who we might not be able to reach, and the only thing that they know to do is to come in. And so for our team, we have, and for many of the service lines across HCH, we have decided to maintain those walk-in hours. So if a client is needing to get a hold of us, they know that they can come in during those pre-existing walk-in hours.
So I would just add in terms of what we're doing for folks around telehealth. So they're in a few different realms. So in the shelters, we have really changed, I'll back up. At Unity Healthcare in general, in the community health centers, we're changing the way that we practice medicine, and we're doing a lot more telehealth as people are doing all over the country. In the shelters, it's a little bit trickier. How do you do that? But we have tried to get the word out to all the shelters that anybody who has a phone who wants to call in to schedule a telehealth visit, they can get a phone call back from a provider to assist with medication refills, et cetera. They can also, if they don't have a phone, go to one of the case managers at the shelter so that they can have a telehealth visit facilitated from the shelter directly at a landline. In the shelter, there are some spaces that have been identified where that can occur. And then for folks on the street, I think it's about getting the word out. So for people who have a phone, again, they can make those calls, but then we have relationships with case managers and outreach workers throughout the city, and so if we partner with them to schedule a telehealth visit with a client, then we can sort of try to make that connection to make sure that people get the care that they need and the medications that they need. At the isolation and quarantine sites and the PEP-V sites, the one really good thing is that every single person has a phone in their hotel room. And so we are really making use of telehealth at the hotels, even though we're physically on site, because of the volume of people that are here and the number of people that we need to make contact with. We're mostly doing these through telehealth, and also because of just concerns about staff safety and communication, preventing spread of COVID between staff and patients, or vice versa. We are calling patients in their rooms, and And somebody did ask a question about sort of what the level of support staff is on site at these isolation and quarantine sites. And I will say that we've been open at the isolation and quarantine sites for probably 3 weeks, and the PEP-V site for 2 weeks, and we have been severely, severely, severely understaffed. So unfortunately, this was a situation where the Department of Human Services felt like they weren't, well, how to state this. So the Department of Human Services really felt there was a need for them to step in and take action to protect this population. And essentially, for the past few weeks, I have been the sole provider on site at the 4 different hotels. The only person with access to our electronic medical record, and Department of Human Services has contracted with a staffing agency to hire nurses to do the phone calls. And so we are really, everybody says we're building the plane as we're flying it. I have never felt that way more. We are truly learning every day about mistakes that we're making and how to correct them. And the one really good thing is that my organization has now figured out how to partner directly with the staffing agency and bring more Unity personnel to the table. So we are getting up to speed, but it's been a difficult sort of bumpy road. So when it comes to kind of all the support services that we're used to in the clinic with case management and peer support and mental health support, we have had none of that, and we are now, just yesterday, we got a nurse psych NP who came on board, and we're thrilled that she's going to be able to help us not only provide direct care through telehealth or maybe even face-to-face with some of our clients, but to help kind of facilitate the connections with people's existing mental health providers. She has a background at one of our core service agencies, and so she knows those relationships really well.
That's great. What incredibly challenging context everyone is working in. It's inspiring to hear all the creative ways folks are coming up to meet and respond to these needs. I'm going to pivot here a little bit because many folks have brought up the challenge of substance use in this context. Providers have asked about clients who are in isolation and are also dealing with substance use disorders. I want to point out that the Council's next Town Hall webinar, which is next Friday, April 24th, will focus entirely on responding to clients who violate isolation orders. And you can all click on the link in the resources pod that's the bottom link, COVID-19 Town Hall series. Clicking that link will take you to the registration page, and so you'll be able to join that specific conversation next week. But I wanted to ask you, Lawanda and Catherine, do you have any advice on supporting clients in situations of isolation and quarantine who are also dealing with substance use disorder?
Yeah, so I think if I were to say there's anything work-related, that keeps me up at night, it is the risk of overdose during this time. It's something that is always a concern. Certainly I have lots of concerns about it as people are isolating as they should be. And I think it goes back a step to say, and I think this may have been mentioned in the chat as well, that when we talk about social distancing, I've been trying to be very intentional about making this distinction between physical distancing and social distancing. This is not to say that the language that we use sort of globally around this is not it's not adequate. But I think I've been trying to think through and really use language with our clients that is really exact. And I think what we need to do is physically distance ourselves, not necessarily socially distance ourselves. But I think that said, and I think for some clients that reframing has been really helpful. But I think that said, with, the fact that substances and substance use is a reality of some of our clients' lives, and will be a reality of some of their lives, I think, this epidemic has pointed out the need for increased harm reduction approaches to the way that we do work with individuals. Certainly some of what we're seeing in Baltimore is that, there are certain areas where substances are easily attained still. There are some places in the city where it is not. And so a concern, I've heard things around people wanting to get, as much as they can because they're not quite sure what that will look like in terms of being able to access the substances that they're using. And so there's concerns about people doing that and having more of those substances available to them. There are concerns about people isolating and not maybe using as much as they had been. And then once quarantine is over, what does that look like in terms of people restarting the current level of use that they had prior to COVID-19 and the risk of overdose as it relates to that? So I think one of the things we have been trying to do as an organization that has a pretty robust representative payee program, which is for people that might not be as familiar with that term, it's really when someone is receiving public benefits through the Social Security Administration, and someone has indicated for whatever reason that that individual needs some assistance and someone assigned to manage their SSI or SSDI benefits. So at Healthcare for the Homeless in Baltimore, we have a program for our clients that allow them to participate in that, and we serve that role. So with that, this past month actually was the first month that we have given clients their funds up front, and all of it at the onset of the month for those who wish to have it. One of the things we had a lot of concerns about, and our clients expressed a lot of concern about, was having access to their money. And again, I think the stress and the mental health challenges as it relates to the uncertainty of not knowing how you're going to access your funds, if the agency will be closed, if they will be able to get their money, what happens if we do close. And so there were a good number of clients who elected to get all of their checks, their distribution checks at the front of the month. And so we had to think really critically about and recognizing very honestly that that puts people at risk for having, more money available to them than they would have ordinarily based on their typical distribution patterns. And how do we think proactively about engaging people in that dual conversation about, yes, we want you to have access to your money. Yes, we fully recognize that there's a level of uncertainty that comes with this epidemic, and certainly recognizing that the impact of that uncertainty will feel different to our clients than it might feel to us from an economic standpoint. And at the same time, this really sets you up to have a lot more money available to you in a way that could impact your use patterns. And so we did a push to make sure that everyone who was coming through our doors had access to Narcan. And so for people that did not have Narcan available to them, we had Narcan in hand, and were ready to do and did education with individuals right there on site when people were getting their checks and making sure that they had it available to them with no barrier. And I think, we will have to think really intentionally about how we support people through this time. I think one of the things with people in isolation, sometimes people come out because they're trying to secure their drug of choice. Sometimes people are coming out for other reasons. And I remember having a conversation very recently with someone about the fact that if someone is having a difficult time staying in isolation, that we not assume we know the reason why they are. A person could have, a history of substance abuse and be coming out and being with others when we should be physically distancing ourselves for reasons that are completely unrelated to their substance use. And so I think the first suggestion and piece of advice I would give to people is to ask and clarify. People come out because they want to see a loved one. They come out because they're following and trying to connect for romance. I mean, all kinds of things. And so, or to seek services. And so I think we should ask. We should clarify and ask. And I think, doing that in a non-judgmental way. And I think there's a sense of normalization that can happen and asking and kind of acknowledging that it's very difficult to stay indoors. I think we all have had a collective global humbling experience with our own challenges, with not being able to go and move the way we want to. You know, even if you never had a desire to go a certain place or do a certain thing in the past before this epidemic come upon us, you might have desire to do those things now just because you can't. And so I think that's important, like that human element is important to recognize in the most non-judgmental way possible, because this is an experience, I think, that's a shared one. And there's a lot of, I think there's a right potential. We talk about a lot of the negative consequences and impacts of this epidemic. And I think as we talk about isolation, there's a bit of normalization just in having that empathetic, you know, human connection with another person as a shared experience that can help decrease that sense of isolation and depression quite a bit.
Thank you, Lawanda. I completely agree. Again, I think that that there are so many reasons why people might go out of quarantine that have nothing to do with their addiction. And I am a huge proponent of harm reduction now more than ever, especially in these isolation and quarantine sites. So the way that we've seen that here is, again, I mentioned nicotine and Suboxone, and really having ready access to those things, which we have not quite figured out. We would love to have just patches in bulk so that if somebody does want a nicotine patch, we can offer it to them immediately as opposed to having to prescribe it and then wait several days for it to come, because several days of no nicotine for somebody who smokes half a pack a day or a pack a day is not gonna go well. So trying to figure out how we can get those things on site. The same for Suboxone. So we have a number of our providers are Suboxone prescribers, which is wonderful. And so sometimes we've been able to literally, as we have been doing the screenings on site at the shelters, if we know that somebody uses Suboxone or uses heroin, for example, and is open to being on Suboxone while in quarantine, we've had prescribers who will literally send in the prescription and then bring over the Suboxone that same day, which has been really helpful. I should say that's something that we're doing. We've sort of closed our clinics as usual, but we're going as teams shelter by shelter and doing shelter-wide screening for symptoms and then referring to the isolation and quarantine sites as we find people who are symptomatic. And so we've been able to kind of try to get a sense of what's going on sort of shelter-wide. So getting the nicotine, I think, you know, maybe having cigarettes, but it's hard because the Department of Human Services really feels like that's not their place to be handing out cigarettes, and different people at different shifts kind of feel differently, and so there's inconsistency there. At the PEP-V site, this kind of isolation or quarantine site, I should say, for the high-risk folks who we're trying to proactively protect against this, we have decided, or the Department of Human Services rather, is working with the hotel to set up kind of a canteen where the hotel will sell, hopefully at a reasonable cost, beer and cigarettes and pizza and wings is the thought. And then so the combination of having some alcohol available on site, Suboxone on site, nicotine patches on site, that we can really meet the needs of some of our patients. We actually did have a situation at the PEP-V site where one of the clients was seen selling crack to another client, and there was some question about whether or not that person should be asked to leave. I thought that there was maybe something sort of nice about having somebody who had access to what people needed on site, but and I think that person is ultimately still there, and I think they're working through it. So absolutely, I think harm reduction is the way to go right now, and just trying to figure out what different organizations feel comfortable doing.
Sure. I want to highlight a brand new resource that the Council has just published on harm reduction during COVID-19 for people with substance use disorders. So if in the resources pod, if you click on that NHCHC COVID-19 resources link, the very top material on that page is the new harm reduction resource. So make use of that if it's helpful to you. Now let's talk about ways of responding to folks' mental health needs that arise from this situation. In what ways can clients use their physical environment and or virtual connections to decrease depressive symptoms, for example?
Yeah, so I would say one of the things that I've been talking with clients about, and primarily our clients that I'm working with on our project in Baltimore, they are housed. But I would say that use of physical space is really important. So I talk with clients pretty intentionally about how they surround themselves with things that make them feel comfortable. You know, I've talked and taking good care of themselves. So I think that's one thing, and having lots of conversations with clients about the idea of self-care during this time and being forgiving with oneself. But I think the use of light is really important. Oftentimes when we talk about isolation, we think about this in this, I mean, the image that comes into my head is sort of like this dark cave. And so really talking with people, you know, asking them what they see when they think about the idea of isolating and really helping to make those distinctions between cutting oneself off physically from other people out of necessity for health and wellness, but also maintaining those social connections and how you can do that. And those are connections to people, but I think connections to things that are important to them as well. So, you know, encouraging clients to open their blinds, open their curtains, open their windows, breathe in fresh air. You know, in your bedroom, if you have a window, you know, I've talked to clients about opening their window if they feel safe to do that, and letting the birds chirp and listening to that and just being present in the moment. But I think I can't underscore the impact of light, you know, and fresh air as it relates to elevating one's mood. I think that's really important, and it doesn't cost a dime, actually, to do that. The other thing that I've talked with clients about is we have some clients who have a green thumb, and so I've talked with clients about moving plants that they might have in their home in spaces that are more visible to them. You know, being able to take care of something that is living, you know, is very comforting and can be helpful and give people a sense of purpose. And so engaging with your pet, you know, taking your pet for a walk, you know, caring for other things that are important to you can be really helpful. You know, I've talked about the use of journaling and having a space in one's home to do that if that's something that's helpful to people. So I think, you know, there's a lot of potential in terms of using the space, particularly when you're housed. It's very difficult to do that when you're not in a space that you have complete control over. So it's very difficult, I would imagine, for individuals who are living in a shelter space. I think that there are things that perhaps shelter providers could do as it relates to those kinds of things to help create those spaces that bring brightness and light, you know, and openness and light into those spaces. So I think it takes a little bit of thought and creativity, but I absolutely think that one could use their physical environment to help promote a sense of wellness and to decrease a sense of isolation and depression.
Hey, this is Catherine again. So I think I'm sort of standing here in one of these physical spaces, and what I have noticed for the hotels is that for some people it actually is kind of a respite from the overcrowded shelters, and people have their own private bathroom, and they have their own private television and bed, and they can while there's a sense of not, nobody's being held against their will, right? So people, theoretically could come and go if they want, but they're being encouraged to stay put for their health and for the health of other people. But I think that I have definitely seen sort of on the flip side of the being cut off from service providers and maybe withdrawal or substances that they don't have access to, there is a sense for, I think, a number of people that this is something that is has been a sort of a positive thing for them. And there are certainly people that we have seen who they've finished their isolation and they're free to go, or they test negative and so they're ready for discharge, who have not wanted to go. So so just that's sort of the flip side of the isolation and quarantine. And actually the PEP-D site, which is this high-risk site, I have a number of patients who are there who I have never seen better. They are thriving in a way that I think is something that I would love to kind of replicate this sense of, because they're people who don't have COVID, who've kind of gone through a 14-day quarantine period, so we hope that they won't develop symptoms. And it's kind of almost like an assisted living for people, sort of vulnerable, older, medically vulnerable folks who have nursing on site. They have their meals provided. There's sort of a community room where the chairs are all spaced 6 feet apart, but there's music, and there's kind of a back patio area for the hotel where people go out and smoke a cigarette. And I just think that many of my patients are thriving in a way that I have not seen before. And so that's a little bit on the flip side. And I will say, so there was a comment that I am not a psychiatrist. I am a primary care provider. I think that as a primary care provider who cares for people experiencing homelessness, a lot of my patients have more of a relationship with me than they do with a mental health clinician, because of the fact that there's a lot of times lack of insight into mental health diagnoses and stigma around mental health conditions. And so I think that primary care providers really do provide a lot of that mental health support that we see, even if it's not in the form of in the form of psychotropic medication. So really, I do think that maintaining that connection with between the patient and the clinician, if they do have a psychiatric clinician, and also just sort of facilitating general connection to caregivers in their lives is really important.
Thank you. And thank you for the really active chat that's going on. There are so many folks sharing resources and ideas, and I'm not going to be able to call attention to each of those, but we are recording the chat, so if there are questions that don't, people asking for specific materials that we don't get to today, we can follow up after the chat, and just really appreciate the way you all are supporting and sharing with each other there. So just as homelessness disproportionately affects people of color, COVID-19 is more profoundly impacting people of color, not surprisingly illustrating racism as a root cause of health disparities. So people of color may also experience more microaggressions and overtly racist acts as general stress levels rise. Recognizing the trauma that this can cause for individuals and communities, do you have insights on the role that providers can play in supporting both systemic and individual healing?
Well, I would say I think it's important. The very first thing that I think as providers we have the most power and most significant way that we can be helpful as it relates to this is acknowledging a thing as a thing. So I think validating that this is a serious issue. It's not a new issue. We know that health disparities among people of color has you can look at any research out there that can show that most disease processes more disproportionately affect people of color and people that are marginalized and people that are living in poverty. So I think acknowledging that this epidemic only magnifies and highlights where those things have always been true. And I think recognizing that and validating it is extremely important. It helps people to recognize and know that they're not making this up or that this is just something that they're feeling and not something that is actually valid. So I think that's very helpful to validate it. I also think talking through it, this comes up very often, especially now in some communities where people are in positions and there have been executive orders that face coverings are mandatory. Navigating in the cities, in some cities, maybe not all, but navigating through some cities and some communities with your face covered as a person of color has a lot of implications for people. And I think that's important to say and to note. So, as we are only supposed to be traveling, for essential activities, even attending to those essential activities as an individual who has to cover their face and feeling that puts you at increased risk within your communities can be not the greatest thing for one's mental health. And I think the stress of living as a person of color in some communities already has been challenging for people, and I think this only magnifies that. So I think, helping people to recognize that this is actually, their experiences are valid, and talking about what that has been like for them and how can they navigate those things, and helping to reassure folks, helping people to find resources. I've had lots of conversations with people here recently as more data has been coming out from various governmental agencies about this health disparity. It's been a huge topic of conversation among clients that I work with, and about staff who work with clients who are people of color. And so I think it's been one of those things that we have to start by validating people's experience and their concerns, and they are not off base or making things up, or it's not all in their heads. These are true experiences. And I think from an advocacy standpoint, I think we as providers have an opportunity to really think about how we deliver services to individuals based on this information. And I think making sure that we are helping clients to get access to the services they need to help mitigate some of that. So how do we think creatively for people who have those kinds of fears to be able to still get access to the things they need? We have some clients, I'll tell you very honestly, in Baltimore who are not going to come out of their homes because of this. And they just don't feel comfortable. And I think, really being an ear for people to speak voice to that can be tremendously healing.
I totally agree. I think everything that Lawanda said is right on point. I think the validation on a personal level and just recognizing that this is absolutely true. I can't tell you how true it is here in the 4 sites where I have been checking folks in and doing outreach to. I would say it is almost 100% people of color and African Americans, and it's so I think keeping the data on that and really continuing to hold that up to the public and to say, like, this is what's happening and it's not okay. And so we are tracking that data when we're ordering the tests. We weren't doing it initially, but we have started tracking for reporting purposes gender and race. And I think that, really sort of at a systems level to put that out there, to advocate for change, as well as on a personal level to sort of have that data out there and being publicized, I think is very validating for folks to know that, like, this is a real problem and that we need to pay attention to it. Absolutely. So I couldn't agree more. And you know, one thing I will just say also is it's not just people experiencing homelessness. I think it goes to disparities across kind of who's at risk because of socioeconomic status, and people who are poor and rely on, you know, having to go to work to do whatever it is that's now being asked. I see the people who are in their hazmat suits cleaning the rooms, the hotel rooms for people who tested positive, are almost 100% people of color, people who are going to the jobs at grocery stores, et cetera. So this disparity between kind of who has the privilege to sit at home and telework from their computer and their, you know, all of their space and amenities in their home versus who really doesn't have that sort of luxury to make a living by staying at home, and how that puts people in direct harm for, or, you know, exposure for this, and how that really falls along racial lines.
Sure. Also, if any of you are in areas where your state or local health department is not reporting COVID-19 data by race and ethnicity, that's an advocacy opportunity for us all to make sure that attention is being given to these disparities. All right, we are just past our 1 hour mark. I want to thank you guys so much for being part of this chat today and for the participants. Before we close, I wonder if Lawanda and Catherine, if you wanted to share any final advice about how providers can tend to their own well-being?
Yeah, I would say do what you love and save quantities. So I say this because I will share with almost 250 people that I love ice cream, and so I have been a little bit beyond my limit, but doing that in a way that is very safe still. So, you know, I think being forgiving with yourself, I think being kind to yourself, and recognizing that this is a global collective experience. There is solace in normalizing this. We are not in this alone, and I think when something novel happens, there is not a expectation of perfection. So we are building the plane as we are driving it, or flying it rather. And I think just being as loving and kind and as patient with ourselves as we can be allows us to be able to give that same lens to the people that we're working with. And I think just extending grace where we can would be my advice.
I think those are great points, and I would also say that sleep is important, and I need to follow that advice, having slept 3 to 5 hours a night for the past few weeks. So having that kind of downtime to regroup and come back fresh the next day, because this is not a sprint, and we're going to, I think, unfortunately be in this for a little while. So sort of figuring out how to pace ourselves, and like Lawanda said, give ourselves grace and forgiveness if we don't get everything done in a day that we feel we should have gotten, because honestly there's not enough time in a day to get everything done that has to be done right now. You know, doing the things that give you joy, like Lawanda said. I think getting fresh air, if you are lucky enough to live near places where you can go outside. I think Washington, D.C., we're very lucky to have Rock Creek Park, and it's a lot more crowded these days than it used to be, but there's still a lot of open space where people can kind of, I think, fairly safely walk 6 feet apart from one another. So you know, I would say exercise. I haven't done that for a little while, but you know, all the sort of tools that we turn to in the common sort of stresses of our daily lives, I think we need more than ever. So I would encourage folks to do those things, and as Lawanda said, to try to do them safely. You know, I'm drinking probably a little more wine than I usually do, but I think I'm doing it safely. And you know, just taking that time to sort of like regroup and relax a little bit.
I love that, and I'm putting ice cream and sleep on the top of my to-do list for the weekend. Thank you both for your candor and these ideas, and for all of the attendees who shared your challenges and the cool things that you're doing. It's been wonderful to be together here today. So thank you all for that. A brief evaluation will appear on your screen shortly. So if you would take a minute to just share your perspective and help us plan future sessions, that would be really helpful. But may you all be well.
Thanks, Lily.
Thank you.